So at this point, I'd like to invite Dr. Charles Phelps to come up and to give the committee and the audience an update on smart vaccines. Dr. Phelps is a member of our committee, Provost Emeritus and University Professor of Economics at the University of Rochester. And Chuck has done a lot of work for us on this, and I thought it was appropriate to have him bring us up to speed on where we are. Chuck?
Well, good morning to you all. I'm going to try and walk through where we've been in phase one fairly rapidly. Hope we'll have some time for questions along the way. Summarizing the work that's available in the report, which I hope you've had a chance to read and prepare, at least glance through. This was the report of phase one. The task was to structure a model that would be useful in setting vaccine priorities, not to create a list of vaccine priorities itself. And in doing so, in developing this model, we had a series of considerations that we thought were quite important for us to embed. The first is we wanted to have this accessible to people coming to the problem of vaccine prioritization from different viewpoints, multi-stakeholder application, so that people that came to this from public health, from vaccine manufacturing, could all have their particular set of priorities available as evaluation tools. Second is we wanted the tool to have an axiomatic foundation that was solid, that was not susceptible to goofy results because of particular inputs. The model we chose to use, the multi-attribute utility theory, in fact, has well-established capabilities in that area. It is not easy to address to first-time users, but it is axiomatically solid. Third, we wanted to have a priority scale that came out of the model. The multi-attribute utility theory produces a scale that I would say is simply akin to thermometer, such as Fahrenheit or Celsius. The difference between 20 and 40 Fahrenheit is the same as the difference between 40 and 60. But that's not the same as 20-point difference in Celsius scale, and the scale that emerges from any single user's use of smart vaccines, in fact, is sensitive to their own preference statements that they put in. We wanted the ability to embed analysis of sensitivity. A lot of the things, data coming into this model are in fact unknown. What are the characteristics of vaccines that will be developed? So we have built in some, and we'll be enhancing those activities for sensitivity analysis. Transparency is a little hard to talk about in a model that's fairly complicated, but we believe that the structural basis of the smart vaccines allows for and creates a sense of complete transparency in the following way. Different people, as Dr. Gelland said, are going to have different preferences that they put into the model. They may also disagree about what the attributes might be about a future vaccine, but they will be able to compare what they have put into the model and use it as a discussion facilitator, hopefully to reach convergence. And we hope in the end to have user-friendly software, although we are obviously not in that position immediately. The multi-attribute utility framework is complicated. There's just no denying that. The inputs on it, a lot of demographic data and disease characteristics. I'm going to show you screenshots of the model as it moves along. You'll get a little more sense of these. And characteristics of potential vaccines, these are all input into the model by the user. The demographic characteristics we think can be imported in general from outside sources pretty readily. This will then lead to calculations within the model of unvaccinated and vaccinated populations. And then from there, calculations of a lot of specific health outcomes, cost outcomes, and combinations of those, such as cost per quality adjusted life year or cost per disability adjusted life year, are available and immediately accessible as part of the program's output. Perhaps the most novel part about smart vaccines is the value model. This is the one place where users can describe their own preference structures, set the rank order and weights attached to these various attributes they think are important. These combine with all of the output of the model, quality adjusted life years, economic costs, cost effectiveness, many other computed characteristics, and then other more subjective characteristics that have, until this point, necessarily only been weighed as a part of a global gestalt in an analysis. These are now actually visible as to what somebody has said. How important is it to favor disadvantaged populations, or how important is it to have this accessible for an area without cold chain requirement, these sorts of things. And these come into the model as well as attributes through the value submodel and create the value score that ultimately shows up in the final model. There are 29 attributes that are grouped into 8 categories. I will not have time to go over each of these 29 or the 8 categories. I'll give you some examples along the way. But for example, health characteristics, premature deaths averted per year, incident cases prevented per year, and quality adjusted life years or disability adjusted life years. Either qualities gained or dollies averted. You can only use one of those, otherwise you'll have double counting. Economic considerations, cost effectiveness, and one-time and annual costs of carrying out the program. I want to step down to some of the less quantitative and intangible values. For example, does the vaccine eradicate a disease completely, such as we hope might soon happen with polio? Does it raise public health awareness? Will it advance foreign policy goals? These are the type of subjective attributes that we user may or may not enter as they wish. We were charged in the first committee of having several test drives. We chose influenza, tuberculosis, and group B strep in the United States, and tuberculosis in South Africa as the test beds, and there are data on those in the first report. So before I launch into a description and overview of the current operational version of it, I want to make sure we have the disclaimer clearly in view. Dr. Gellin mentioned this as well. This is not a decision-making tool. It is a decision-advising tool. And we hope it will also facilitate discussion among people, parties, different viewpoints, as they come into using this model. When they have disagreement about what the final list looked like, they should be able to nail down why. Is it because they believe have different attributes of the vaccines, or whether they have different values they put on those attributes? But it should be clear that this is not a list that is programmatically and mechanically designed to go out and rank order priorities for vaccination. It's a tool to assist decision makers in thinking about it and in organizing very complex data. Step 1 in the smart vaccines and our beta test, Dr. Gellin, you're asking about which version. Let's just use the Greek letter beta for now. Selection and ranking of values. This is a screen, as you can see the animation of this, that allows users to drag various attributes into the box, and then, if you wish, shift the order of them around. There's a subprogram in that gives an approximation of what one might do in terms of numerical values attached to these rank orders. It's not the only way that we can put the value structure in. I'll show you some of our work later on, but right now the current software has this numerical approximation that just is simply a calculation off the rank order, gives you the weights. Step 2 is the population profile. Again, this allows you to bring in data from outside, typically, for example, in population data from World Health Organization databases that describe what looks to be very complicated sets of data that have population profiles, economic data, life expectancy data in each population. This is a necessary component to make the model work, as any population that needs to be considered has to have these kinds of data brought in. We've tried to make this so we can use externally available data sources as much as possible. But it looks like it's the most daunting because of the complexity of the data, but we in fact think it may be one of the easier ones because of the ability to import external databases. Step 3 is to characterize the profile of the disease being approached. So again, we have here examples of influenza. So attributes about the disease, what's the annual incidence rate, what's the case mortality rate. These types of disease data reflect what would happen to an unvaccinated population. There are also discussions about what the costs of treating the disease would be if it's left unchecked. These, again, are going to be specific to the population in the region of interest, so that the ways that influenza is treated in the United States will differ from that in other countries, as well as, of course, the incidence. So tuberculosis, one of our test cases, is obviously a much higher rate of incidence in South Africa and other nations than it would be in the United States, and hence the data and costs of treatment and all of these will differ from country to country. Step 4 is a profile of the vaccines. And again, Dr. Geller made this point. I want to make it again forcefully. These vaccines do not yet exist. So these are estimates by experts about what the vaccines will be able to do. Again, specifying, for example, what will the coverage rate be, what will be the uptake rate among the population, what will be the effectiveness rate of those who are vaccinated, and also costs of the program are input at this point, and also the other special characteristics, one-time costs, and again, attributes, does it benefit infant and children, particularly these sorts of attributes. All these are country-specific, disease-specific, and vaccine-specific. Ultimately, end users are going to probably be working in teams with assistants or associates entering these data at the population level, and then high-level decision makers using the software in concert with their colleagues at this sort of type of a setting. Step 5 is the qualitative attributes. Again, these are things that will differ from vaccine and setting. So one-time costs, are there specifically, for example, productivity gains? Is there a quality adjusted life years gained or dollies averted are all characteristics of these. Demographic considerations about each vaccine. Do they benefit infants and children specifically? Do they particularly benefit women? These are considerations that may or may not be important depending on the vaccine and depending on the viewpoint of the individual involved in making the assessments. Step 6, a large computational engine that then assembles all these data that have been collected. Some of it objective population data, economic data about population income, wage rates, and some of it the subjective data that have been entered by the user about characteristics of the vaccine, such as a thumb on the scale for infants or women, something like that. So these computed results then come in, and here you can see the model will produce measures that have been fairly standard in past reports. It will produce estimates for each of the vaccines under consideration. In this case, A, B, and C are tuberculosis, group B strep, and influenza. And it'll calculate the health gains, it will calculate the cost of running the program, it will calculate the cost per quality adjusted life year. These are all these relatively more objective criteria, including single criteria that have been used in previous IOM analyses. Now, of course, in the value structure, if somebody has specified that they only care about one of these, so for example, health gains for the population, and that's the only attribute they've counted, then this model will in fact calculate exactly what previous reports have done. If they specify cost per quality adjusted life year as the only attribute of interest and importance, then the model will give ultimately a ranking for that population across the vaccines being compared. It'll give cost per quality adjusted life year cost effectiveness analysis. And if other considerations wish to be entered, they also enter the calculation with the weights assigned by the user. Step 7, the priority score emerges. And here you can see the demo model is shifting around the rank order of these characteristics that have been desired. And all that flew by, but the value scores change as you shift these ranks around. The value scores, the final numerical total that's given, again, like a thermometer scale. These value scores can depend directly both on the characteristics of the vaccine that have been estimated, but also, and uniquely in our approach to this, how one ranks these attributes. So if premature deaths averted per year is highest and one-time cost is second, benefits for other priority populations is third, and fits into an existing immunization schedule is fourth. If you shift those around, these ranking scores will change. Okay? Some sample scenarios. We think this might be used. For example, you might have a different viewpoints, a minister of health in a single country versus a multinational consortium. Obviously, the multinational organization would want to aggregate up the populations of all their constituent members or those populations they were interested in, but those would lead to different viewpoints and possibly different rankings. One could also think about the perspectives of a basic research organization such as the NIH or Wellcome in Great Britain versus what the perspectives might be of a vaccine manufacturer. They would be able to look at the potential vaccine development from their own perspective using this tool. One could also look at the same values. People agree on the value structure, but then start altering the attributes of a vaccine. So for example, is it 1 or 3 doses required? That obviously changes the coverage rate in the field, among other things. Is it oral versus injected? Is it annual versus lifetime immunity? These are all decisions about vaccine development that people are grappling with in the real world all the time. Vaccine manufacturers will be thinking about this in terms of the complexity, the likelihood of success in development, the scientific risk, the profitability. Others may be thinking about this in terms of the field operational implications. So the program is accessible for using, even with our full agreement about the value structures, for comparing different types of vaccines and saying, you know, I think that might be important, how much, let's look and actually see how these different attributes would weigh out in, with agreement upon the values. As a work in progress, I can't give you an operational version of this at this point, but one of the things we've been working on is ways to alter the weight setting process. The earliest versions we had simply made a numerical approximation out of the rank order that people put the attributes in that they listed. We've developed a tool that has, for each of the attributes, you can check off, is it turned on, yes or no? If it's turned on, there's a slide bar where you can run the weights up and down for that. And in this version, again, I'm not able to show you right now the active version, but as you slide one of these sliders around for one of the weights, you can watch all of these vaccine priority scores change. It's a very useful tool for this. It's a work in progress. This is kind of our laboratory test bench, if you will. We've made some mention of this in the phase 1 report, but not shown the exact detail of this. But this is something that the committee will be using as a kind of an early on test of different ways. In fact, of things that we learned from you today that will be important. This is probably where we'll first implement these in development to see how they work out. And so this is changing the values, which is one of the 2 major ways of using the software. The second is to change the attributes. Again, given the value structure, which we saw just on the previous page, once you have the value structure nailed down, you can also begin to alter the attributes. And again, you can see in this slide, as you change the attributes from 1 year to 5 year coverage, or change the cost of development, or change the scientific risks of development, if you put value on those in the value structure, you'll see these emerging in terms of the priority scores. And in this version of the software, we actually have parsed out how much of the value score comes from each of these attributes that the user has labeled as important. So this is kind of a testbed model that we've been working on. We think it will be useful for us in making further programmatic developments before we really go full bore into the final modeling. And that'll be one of our tools along the way. So additional considerations, Dr. Gelden's mentioned some of these as well. The software puts some fairly heavy data demands on the user, each user one at a time. Population data. data about treatment of the disease within their population, in their own setting, data about the treatment of side effects. I didn't mention that before. If the vaccine's got potential side effects, such as Guillain-Barré or something of that order, what are the costs, what are the incidence of those side effects and costs? We allow the treatment of side effects differently than the native disease itself. Subjective weights, we said, are approximated in the current model. We're working on ways to enhance the ability of users to specify those directly. We do not yet have distributions around the data. So there's static fixed numbers about what is the cost, what is the population size. In fact, there are about 4 or 5 estimates of the population of the United States even. So when you can't say that even that is known with certainty. And so we want to, in fact, we can, in the earlier models, allow you to play with these attributes and see what happens to the priority scores. We will be looking for ways to enhance the ability to improve what I would call understanding the uncertainty around the input data. There's also the question about whether one wishes to analyze this in a steady state population once the vaccine program has been implemented and is in full bore, or whether you want to be able to analyze it in a startup situation. These are all considerations that either the next version or hopefully later versions that emerge will grapple with. And finally, the current model does not deal with disease interactions. Probably the most important of those would be HIV coupled with things like tuberculosis. That's a very complicated modeling problem. We have not solved it in our current version, nor to my knowledge have any other approaches to vaccine prioritization dealt with those issues. So today's workshop, we're seeking your feedback. In terms of model refinement, software enhancement, we'd be interested in what you think would be important vaccine candidates for us to consider. Ways to handle uncertainty and sensitivity, which approaches would be most useful to you. Ultimately, when a test drive model is available, rather than looking at I thought it was a very nice analogy from Dr. Gellin. You have the professional driver driving the car around, and you'd like to be able to drive it yourself. And just want you to also be aware, we may have a base model Honda rather than a Ferrari here. Don't please expect a Ferrari on this version. And then ultimately the recommendations we make to our sponsor in a variety of areas, including how to make this more long-lived, as Dr. Gellin has mentioned. So that will end my presentation at this point. Do we have time for questions, Lonnie? Yeah, we'll take questions. Yes, sir, in the back. Please come up to the microphone and identify yourself and state your question succinctly, please.
Slides depicted an area of the model that deals, yes, that one.
This one?
No, back one, or forward.
This
yes,
one.
The animation that you walk through seemed to be dealing somewhat more with the computational submodel in terms of health considerations, epidemiological information, et cetera. And in the animation, it wasn't as clear about how what I'll call the value submodel plays out, especially as you're moving down those 29 attributes into policy. Could you elaborate on that a little bit more, because it was a rather mechanical data fill.
I totally agree. It's really hard to demonstrate the capabilities on the fly here. Yes, first of all, the user, let me just talk about this process in a little more detail. The user starts by selecting which of the category of these 20, we have a list of 29 available. User can add their own, actually. But we start out with this list of 29, and the user simply decides which of these are important to them. So in the current working model, they can just simply drag them over to the list. So you get a list of 3, 4, 5. If you get up to more than about 5, there's not very much weight put on the ones at the bottom of the list anyway in the current approach. But you could put in 5 and put 20% weight on each one of them if you wished also. So That gives you which things you think are important and basically how big a thumb is there on the scale for each of them. And in the current model, if you shift around the ranks, it changes the numerical value attached to them according to a formula that we've used. It's an approximation. It's the first step in our Model T version in step one, phase one. But ultimately, we want the user to be able to specify those values precisely with thought and careful input from colleagues and associates around them, and probably in some cases, given some national settings, political considerations as well. But those will all achieve, essentially, potentially can be entered in, and as you change those values, then the model then uses multi-attribute utility theory, gives a specific numerical calculation for how much of that attribute is present for the vaccine, how much weight is put upon it. It adds up the combination of the attributes intensity and the weight that the user is attached to it, and then adds those up across the attributes that have been included in the working list, and that gives the priority score. So if you change the attributes value in the weighting in the value model, the final score changes. If you change how much of the attribute is available, what's the intensity of the attribute's presence? Is it really costly or not very costly to implement in the field? Then if that attribute of cost has been included in the wait list, then the final value score changes. So, and this is all done according to in our work with the multi-attribute utility theory, which is axiomatically stable. It's well-grounded. There have been multiple decades of research and many public applications of this approach. There are others as well. We decided to use multi-attribute utility theory in our approach. Did that answer your question, sir?
It was very helpful, the fact that you might select 5 of 29 to have the model and the weighting be sensitive to the eventual score, I think is an important understanding. I appreciate it.
Okay, now the other point I want to make on that is you can select one. So if you want to replicate, for example, the 2000 study that used cost per quality adjusted life year as the criterion, you simply pick cost per quality as the attribute, the one and only attribute. And then it carries forward and does all the computation where that's the only thing that's valued, and you get a rank order of the vaccines you're going to be developing that tells you what it looks like if you're weighting it on cost per quality. If you want to do it on one attribute of life years saved, you can simply put in life years saved or quality adjusted life years saved as the sole attribute with nothing else on the list, and you will reproduce a model as if it had done the whole ranking on that single criterion. But it does allow multiple criteria to enter as well.
Just to follow, as you get to perhaps 10 attributes, let's say 5 at the top cluster and 4 or 5 in the value cluster, what happens to the model? Is sensitivity murky or?
Well, the ones that really matter the most are the ones if you're using the rank order approximation, the ones at the top of the list matter most, and after you get about 6 or 7 attributes in, there's only about 1% weight put on them in this particular weighting approach. But one could put in 10 attributes and put in 10% weight on each one of them. That would be unusual. It would probably not reflect very many people's value structures, but it's possible to do that in the model. Remember, all these attributes are clearly listed so that when people disagree about what the values are, they can first of all say, okay, what did you put in the value model? What did you weight and how much weight? And have a discussion about that. But I don't want to repeat, I've said this over and over again. If somebody comes out and says, the IOM model says that this is the priority list, is making a false statement. The IOM is a tool for users. It doesn't make a priority list on its own, and it never will. And if somebody says that the IOM model has made this list, they're making an erroneous statement.
Thank you very much.
Okay. Yes, sir, Dr. Wittes.
My name is Roy Wittes. For those that don't know, I managed the first study.
Is this microphone on? I'm having trouble hearing, Doctor.
I have one initial question, which is essentially that the first committee did illustrate and show an example of multi-attribute scoring or multi-attribute ranking or multi-attribute utility theory, whatever you want to call it, they rejected the use of that type of approach.
By the first committee, you mean the 1985 committee of the Institute of Medicine, or the
That's-
first committee for phase one?
No, the 85, 86
The 85 committee where
reports,
you were
yeah.
the chief staffer, yes, sir.
They looked at this method that you are now proposing and decided amongst themselves that it wasn't really the best method. Your report doesn't really discuss why you disagree with that opinion. I'd be interested to know why.
So the question, if I can restate it, was that 1985 committee where Dr. Wittes was the chief staff person discussed and rejected the multi-attribute utility theory. And the question is, why did this committee not discuss that further, and why do we accept multi-attribute utility theory? Does that summarize your question, sir? Thank you. I guess there's a couple of things, considerations that might enter that. First is that since there have been a quarter century of development of multi-attribute theory, it has been well tested in many environments. The axiomatic characteristics of it are now very well understood, and I think in general widely endorsed as axiomatically stable. Perhaps the most important reason, in addition to those characteristics of selecting multi-attribute utility theory, is the testimony the committee had in the first phase one committee of this project heard. Numerous people told the committee that although the first 1985 and the second 2000 reports were interesting, they were less than fully useful because there was only one point of view embedded in making the rankings, and people just found that that was a fairly severely limiting characteristic of the early reports. So we wanted to provide something that would expand and open up that characteristic. So again, if somebody wants to use the characteristics of the 85 or 2000 report as the only ranking system, they have that available within this model. But if you wish to allow people to consider other attributes, then you can't do it except subjectively. As you know, the 2000 report that Dr. Lawrence chaired said that cost effectiveness is their criterion, and then it went on to make quite a strong statement saying, when you really go about making these choices, you really have to put other characteristics into the discussion. This allows that, but it does it formally and in a way that's completely visible rather than informally and invisible and subjectively. So I think that was another potential value going to this approach. Is my time up now, Lonnie? Well, one more question, if we have. I'd take one more if we have it. It doesn't appear we do. So it appears I put you all to sleep, and with that, I'll end my presentation. Thank you. Oh, okay. Was there another question? Okay. All right, thank you.
Phelps, thanks very much. We thought it was important for you to have an overview of where we were in smart vaccines as we ended phase one and as we actually get started in phase two, and so that was the intent. Thank you also for the questions from the audience as we move forward.